Canagliflozin and renal outcomes in type 2 diabetes and nephropathy. My name is Daniel Ocampo. Type 2 diabetes mellitus is a leading cause of kidney failure worldwide, but few effective long-term treatments are available in cardiovascular trials on inhibitor of sodium glucose cotransporter 2. Exploratory results have suggested that switch drugs may improve renal outcomes in patients with type 2 diabetes.
The Credence trial was a trial that was designed to study Canagliflozin, which is a drug that people with diabetes take to lower the blood sugar. And we wanted to evaluate if Canagliflozin improved kidney function in people who have type 2 diabetes and have kidney disease with it. Credence showed that Canagliflozin reduced the progression to kidney failure by 30% compared to placebo. Importantly, it also reduced cardiac death and hospitalizations for heart failure by 31%. This finding is really important because it is the first drug in 20 years that shows that you can improve kidney outcomes and the progression to renal failure or kidney failure and hemodialysis in people with type 2 diabetes.
Application in medicine. Patients with type 2 diabetes in albuminuria chronic kidney disease to receive Canagliflozin and oral SGLT2 inhibitor at a dose of 100 mg or placebos. All the patient has a estimated glomerular filtration rates of 30 to 90 per minute. For cesarean albuminuria to creatinine hydrate 300 to 5,000 and were treated with renin angiotensin system blockade.
What this means is it's a total game changer for the management of diabetes. It's a game changer for outcomes for patients with diabetes. They usually have hypertension, dyslipidemia, chronic kidney disease, goes hand in hand with diabetes and with the reason why these patients die, which is cardiovascular disease. So to have this indication, to have this class of drugs, it's just a great time to have diabetes, honestly, if you're going to have it. I would hope that that would be the case. We definitely need to do a better job with monitoring these patients. It's not enough just to look at the estimated glomerular filtration rate in our patients. We have to be looking for the presence or absence of albuminuria. It's actually the presence of albuminuria regardless of where their GFR is. If they've got protein shown up in their urine, they are really at an increased risk for developing diabetes as well as cardiovascular disease. So I would hope that having new tools in our chest can only help providers look a little deeper and do those assessments on patients.
Pros and cons. The Canagliflozin patient has a lower risk of cardiovascular death, myocardial infarctions, or stroke. Cons. Patients who had suspect non-diabetic kidney disease or type 1 diabetes has been treated with immunosuppression for kidney disease or had history of dialysis or kidney transplantation were excluded.
This trial is really important because diabetes and diabetic kidney disease are 21st century epidemics. There are more than 400 million people with diabetes around the world at the moment, and 40% of these people will get kidney disease. Once they've got kidney disease, they're at very high risk of kidney failure, of heart attack, of stroke, of heart failure, and of death. people with diabetes who develop kidney disease have, at the moment, few treatments proven to be beneficial. In terms of preventing kidney failure, only one class of blood pressure lowering agents has been proven to be beneficial, and that was confirmed some 18 years ago. In the time in between, we've had no new treatments for this vastly important problem. So with this trial, we took a drug that's available today for lowering blood sugar levels in people with diabetes, but which we thought may well have additional special beneficial effects for the kidney. And we gave it to people with diabetes who already had evidence of kidney damage, mostly through the presence of protein in their urine. We took 4,401 of these people from over 30 countries around the world, and we gave half of them this drug, Canagliflozin, and the other half an identical placebo, and we followed these people for an average of 2.5 years to see what happened to them. We found a very dramatic result. We found that people who received this treatment had a 30% lower risk of kidney failure and related events. They also had a lower risk of cardiovascular events like heart attack, stroke, or death from cardiovascular causes, and a dramatically lower risk of heart failure. All really big problems in people with diabetes and kidney disease. These results offer to transform the lives of people with diabetes and kidney disease. They can help keep them off dialysis, avoid developing heart failure or heart attacks or strokes, and potentially help them to live longer and healthier lives. So we think these results will make a major difference to people with diabetes all around the world. I see so many patients who have had diabetes for some years and who start to develop signs of kidney failure. Until now, we've, for many of these people, had to just watch them as they progressively developed kidney failure. They suffered from the cardiovascular complications, things like heart attack and stroke, and ended up, in many cases, needing dialysis treatment just to keep them alive. With this treatment, for many of those people now, we can offer them real hope and a better future.
Issues of liquors in Ecuador. The prevalence of diabetes mellitus increasing during the last century, and it's estimated 45% of the patients are not diagnostic. In South America, the prevalence of diabetes and chronic kidney disease is increasing, with a great disparity among the countries with respect to the access to dialysis. In Ecuador, it is the one of the main causes of mortality, principally in the province located on the coast of the Pacific Ocean. The greatest single cause of kidney dialysis is diabetes nephropathy.
The development of diabetic nephropathy involves hypertension and hyperglycemia-induced changes in multiple pathways that contribute to morphological changes in the kidneys. The glomerulus is a globular-shaped structure composed of capillaries that are actively involved in the filtration of fluid from the blood to form urine. With diabetic nephropathy, early glomerular hemodynamic changes include hyperfiltration and hyperperfusion, which result in microalbuminuria. Increased afferent arteriole dilation due to a dysfunction in the vasoconstrictive autoregulatory response contributes to increased intraglomerular pressure, which is associated with greater mesangial cell matrix production. Expansion of the mesangial area, an early morphological change with diabetic nephropathy, is caused by greater extracellular matrix deposition and mesangial cell hypertrophy. This expansion is associated with a decreased glomerular filtration rate and a reduction in the surface area for filtration, which marks the beginning of renal failure. As this process continues, the glomerular basement membrane thickens, and this may eventually lead to glomerular sclerosis. All of these changes in glomerular hemodynamics cause stress and strain on the kidneys, which, if left untreated, may result in renal failure.
Conclusion. In conclusion, among patients with type 2 diabetes and kidney disease, those in the Canagliflozin group has a low risk of kidney failure and cardiovascular.
ABSURD-4D study is the largest ever real-world observational study looking at the risk of amputation in patients receiving Invokana and other SGLT2 inhibitors compared to other diabetes medicines. Now, the reason we undertook this study is that in the randomized controlled trial that we did called CANVAS, there was a small but increased signal of amputation in patients receiving Invokana of the lower leg. We wanted to definitively understand if that risk existed in the real world, and if it did, how large was it, and also to compare that risk with Invokana compared to other members of the SGLT2 class. So to do that, we did a very, very robust, carefully controlled study in the United States in 4 different claims databases, so we can be very certain that we obtained all of the amputation events. It was in 700,000 patients, and it spanned about 4 years. The median duration of follow-up was about 6 months in this study. What we found was that patients receiving Invokana had no increased risk of amputation compared to other antihypoglycemic agents. And when we compared within the SGLT2 class, there was no increased risk of one agent over the other. So we concluded from this study that overall in the general type 2 diabetes population, as well as patients who have existing cardiovascular disease, that SGLT2 inhibitors do not have an increased risk of amputation compared to other agents, and that within the class, no single agent has any increased risk of amputation either. So very reassuring for patients, for physicians, and pharmacists as well.
Thank you.